Professor of economics at the University of Massachusetts, Gerald Friedman was born in New York City in 1955. After graduating from Columbia College in 1977, he worked on the research staff of the International Ladies Garment Workers Union. He moved to Cambridge, Massachusetts to attend graduate school at Harvard, where he earned a PhD in economics. In addition to his 1998 book, State, Making and Labor Movements, the United States and France, 1876 to 1914, Professor Friedman is the author of numerous articles on topics in the labor history of the United States and Europe. He has been a regular correspondent on the economics to television and other media outlets, and a consultant to labor unions and to the legislature of the state of Vermont, and to the campaigns for single-payer health care in Colorado, Massachusetts, Maryland, Pennsylvania, among other states, and, as I mentioned before, to Physicians for National Health Program. Professor Friedman lives in Amherst with his wife and his dog Beowulf. He also has 2 college-aged daughters.
Here's where you've been and where you're going. The top line, the blue line, shows per capita spending on healthcare in the state of, in the Commonwealth of Pennsylvania. That line is going up, 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 up. The lower line shows per capita state income, average amount of income produced in the state per person in the year. The top line, blue line, shows what our problem is. Healthcare costs are growing faster, a lot faster, than everything else. Okay, here's nationally the same basic graph. We were doing fine for a little while. Increasing healthcare costs rising faster than the gross national product, is really something that came out of the 70s. The economists came in and said, oh, we need competition, we need more health insurance companies, we need more co-pays, we need people to pay different premiums according to their condition, we need all different types of health plans so people have more choice. That's the problem, competition. The real problem is we have for-profit private health insurance. And that is necessarily wasteful. Here's the burden of healthcare. This is the share of income going to healthcare costs as a proportion of income by different economic groups. The poorest pay more, the richest pay the least. Right now we assess healthcare as a cost, a flat amount per person. You pay the same premiums as somebody else. If you're sick, you probably pay higher premiums, which makes it even worse. But basically, it's a flat amount. It's like a poll tax, which is unconstitutional, by the way. Healthcare is a bigger burden on the poor and the working class than on the rich. We spend a lot as a nation on healthcare. I mean, this is great. I mean, look at that. There's everybody else in the world. And then you get to the last bar, it's us. I mean, okay, it wouldn't be so bad if we were living to be 90. We're down there, USA. 4 years less than the life expectancy we should have given our spending. Part of the reason we die young is everybody, not just the uninsured, everybody in the United States has relatively bad access to health care. Proportion of the population have any cost-related access problems. Most countries are under 20%. The UK is really good. The proportion of Americans with some cost-related problem is way greater than any other country. 7 times the level in the United Kingdom. Other countries know how to do this. The proportion with unmet health needs, a majority of Americans with below median income, that is, a majority of Americans with an income below $50,000 or $51,000 for a family, have an unmet health need. Something that they haven't addressed because of cost. Everybody knows why costs are rising in the United States. It's because of drugs, drug prices, prescription drug prices, and the administration of the healthcare system. Private health insurers don't just drive up their own cost. They don't just waste money on advertising and sending reps around and billing operations. They make it expensive for hospitals and for physician practices to operate. They drive up everybody's costs. They drive up your costs, which don't go into the gross national product. Okay, administrative bloat is just overwhelming U.S. healthcare. Health insurers alone, $200 billion. the cost of administration of the private health insurance system. Employers spend over $30 billion interacting with the healthcare system. U.S. doctors, the average American doctor, and this is already a couple years old, it's worse now. The average American doctor spends over $80,000 on billing and insurance operations. The average American doctor has more than one person in his or her office dealing with insurance companies, full time. We have more office workers than nurses in this country. More what? Health care office workers. We have more people in our hospitals doing billing than we have beds. More than one billing person in hospitals for every bed. The top line here is the rising number of administrative personnel in our healthcare system. The bottom line, which you can hardly see, is the increase in the number of physicians. That's why healthcare is getting more expensive in this country. It's not the doctors. It's not the nurses. It's the administration. And our healthcare system is uniquely difficult. But this is the proportion, the blue line is the proportion of people who have troubles with the insurance industry. And the red line is the proportion of doctors. Nobody's like us. According to the McKinsey Global Institute, drug prices are 60% higher in the United States. Go to the VA. The Veterans Administration negotiates drug prices. The Veterans Administration, which is smaller than the state of Pennsylvania, pays for its drugs 41% less on average than do the rest of us. If Pennsylvania did that, it would save billions. Exactly how many billions? I'll show you. We spend $850 billion on health insurance premiums, more on drugs. Guess what is the most profitable single industry in this country? Pharmaceuticals, drug companies. They'll tell, oh, we need the money for research and development. You know who pays for research and development for virtually all the real research and development that goes on in American drugs? We do. Through the National Institutes of Health and through the National Science Foundation, through subsidies to Pitt and Carnegie Mellon and other schools. Drug companies spend they spend less money on research and development than they do on handing out samples to doctors. And most of the money they spend on research and development is bogus research and development. It's finding a way to tweak a drug so they can keep it under patent. They call it evergreening. 48% of what we spend is waste. If we could say, well, we should spend no more than Canada does. If you adjust for life expectancy, our lower life expectancy, we're wasting 3/4 of what we spend. And like I said, if we're not going to get those years, then I want my money. Everybody who has studied healthcare on the state level estimates that a single payer system would save money. Unanimous verdict. And most of the studies find savings of at least 15% of current spending. Administrative bloat is no accident. They do what they do because their job is to make profit. And the way you make a profit in healthcare is different than the way you make a profit in other things. They make more money by getting rid of some people. The best way to profit in the health insurance industry is to identify the 10% of your people who are going to cost 70% of your medical losses. That's what they call it. They call it medical losses when they spend our money on our health care. They can reduce their losses by 70% if they can find the 10% of the people who are going to be sick and get rid of them. Now, they may do this by canceling your policy if you get sick, no longer legal. They could do it by, as a company in Milwaukee did. They said, oh, we'll sell insurance to anybody. All they have to do is every year they have to enroll by coming to our office and filling out a form. The office was on the 5th floor of a walk-up. Close to half of the American population is undesirable in terms of the health insurance industry. Find the 10%, drive them out. That's called lemon dropping. That's a term of art, lemon dropping. Find the healthy and recruit them. That's called cherry picking. Okay, so you say, I'm not going to do that. I'm a nice person. I'm a good human being. You know what's going to happen to you? You're going to go broke. And before you go broke, you're going to be fired. Because you're going to attract the sick people to your company. Your cost will go up. You'll have to raise your premiums. Healthy people will say, oh, I used to like this. And I like it that you're a nice company, but it's so expensive. I'm going to go over there to the health insurance for healthy people. And you will be the health insurer for unhealthy people, more and more expensive. That's what competition does in healthcare. Everybody goes after the people who aren't going to need it. And they spend money doing it. They spend your money. These 5 people made $73 million. That guy, United Health Group, $9 million. Single pay is a solution. And it's the only solution because we cannot solve our healthcare problems unless we get the health insurers out of the mix and get control over drug prices. Anything else we do is at best a short-term fix. Not a fix even, a short-term improvement. Single payer would allow us to get rid of administrative waste, would restrict monopolistic pricing, would allow effective management of capital investments. Whew, that's a mouthful, I'm sorry for that. Basically means you won't be allowed to build a hospital right next to another hospital. And single pay would allow us to allocate the burden of healthcare according to ability to pay, rather than, the misfortune of being sick. Nationally, we'd save $220 billion in administration within provider offices. We'd save $100 billion on drug purchasing by bringing prices down to world levels. We'd save $200 billion on administration in the private insurance industry. Altogether, it comes to about almost $600 billion that we would save in the first year of a single-payer system. Now, to be sure, we'd have to spend some extra money to implement HR 676, a single-payer system. And we call this added costs, but a lot of these added costs are benefits. We'd have increased utilization because HR 676 and the Pennsylvania Healthcare Plan assume no deductibles and no co-pays. That's part of where you get savings. You don't have to have people in the doctor's office processing your deductibles and your co-pays. But without deductibles and co-pays, people will go to the doctor more. Well, that's actually kind of a good thing. We have too many Americans not going to the doctor because of costs. But there'll be costs involved with that, $144 billion nationally. We'd have the cost of expanded coverage to the whole population. If we're going to pay everybody out of a single payer plan, we can't discriminate against providers who treat Medicaid patients. So altogether, these extra costs would eat up about $400 billion, leaving $200 billion in just savings, plus better health care. That's nationally. Pennsylvania Healthcare Plan would allow effective bargaining and would reduce the penalty for being sick or disabled. Here's estimates of savings, $32.8 billion. $32.8 billion in 2014. Again, savings from reducing provider costs, reducing drug prices, getting rid of administrative costs of private health insurance, same basic area. And again, note that, often the largest single area of savings is in provider offices. Those of you who are doctors or nurses or work in that area know how expensive it is to process paper at the behest of the private insurance industry. We would get rid of that and allow savings. Again, we'd allow system improvements, increase utilization, covering the uninsured, and fixing the Medicaid rate system. Net savings of about $16 billion in the Commonwealth of Pennsylvania. And everybody would be covered, and you wouldn't have co-pays, and you wouldn't have deductibles, and everybody would be able to get better health care. Savings would increase over time because a single-payer system would allow the rational allocation of capital resources. By reducing drug prices and administrative costs, we would eliminate the largest area of increases. Get rid of the thing that's increasing fastest, and increase slows down. This is the experience of everybody else in the world. You know, in 1971, the US and Canada spent just about the same amount on health care per person. We spend twice as much as Canada now because our costs have risen faster. Most of that is because increases in drug prices and administrative costs in the United States. The Canadian works a lot better. There's where the top red line is estimates of costs of health care for the Commonwealth of Pennsylvania as a share of state income under the Affordable Care Act. The blue line, which is a little bit less, is if you just repeal the Affordable Care Act and don't even bother trying to cover the uninsured. The lower line, the green line, is what would happen if in 2014 you enacted the PHCP. Not only do you get a lot of savings, but the savings grow over time because single-payer system will control costs better. What's going to happen when healthcare costs are 25% of gross domestic product, with or without the Affordable Care Act? They're going to come after services. If we don't control administrative costs and bloated drug prices, then they will come after the services available to people because that's the only other thing. It's all either waste or genuine services. If you don't control waste, then you have to cut services. Insurance should mean that you have a system where the unfortunate are not victimized by their misfortune, or not victimized any further than you're already victimized by being sick and miserable. A single-payer system would take the costs of care off of the backs of those who need care and would be fairer. We could finance it with taking existing revenues and a 10% payroll tax, 3% income tax. That finance would, my estimate is in 2014, there'd be a surplus of about $1 billion. More of the funding would come from the federal government, which is nice. State and local governments, businesses, and households would save. Note, state and local governments have really big savings. Would shift the cost of health care from the bottom 80% of the population onto the top 20%, especially the top 5% and the top 1%. Create jobs. And again, the biggest advantage would be if you do it first. You really want to get going. You want to get ahead of everybody else, because when you have a single-payer system and your businesses are more efficient and you aren't wasting so much money, you're in a competitive advantage against everybody else. Businesses in New York and Maryland are going to be moving across the border to Pennsylvania, where they don't have to pay as much in health care. You get this by getting rid of the profit motive. It doesn't work in health care. Yeah. Everybody has a right to health care. Everybody working together can make it happen. You can do it. Thank you very much.